Okay, so this is a urine specimen. It is actually an instrumented urine from left ureter. So for the instrumented urine, usually the cellularity is high because it's like direct sampling, direct washing from the urothelium. However, usually in the ureter, because it is a very tiny tube, it's a very tiny space, usually the cellularity is not that high. The severity would be higher when we do the pelvic sampling. But in this specimen, as you can see, it is hypercellular. So all these cells seems to be pretty big, and it has markedly increased nuclear and cytoplasmic ratio. The chromatin pattern looks hyperchromatic, but with a very, it's not the usual type of hyperchromasia because you can see the pattern is very ground glass. 啊，喂，是，你好，嘿，哎是，哦哦，在11楼是不是？在11楼，112，哎，那会开多久啊？哦，好好好好好好好好好。So what we like to say this is I just know the English. Dr. Luis told me it is matte black, 消光黑. I'm not so sure why it's called matte black. Probably the first guy who invented this called matte or something like that. So it's called matte black. So you can see it is like a diffusely homogeneous without any like a granular pattern. So this type of pattern can be seen in high-grade urothelial carcinoma. So this one, the case is positive for high-grade urothelial carcinoma. So I would say about 1/3 to 20% of the cases that we see, we have this type of chromatin pattern between hypochromasia and matte black. It is not like a very coarse chromatin. It is very homogeneous. So the second specimen is voided urine from an elder male who is 76 years old. So in this specimen, it is voided urine, so supposedly the cellularity can be low. So this one is getting low. We do have some keratinized cell, probably from the contamination of the skin. So in this specimen, we have large cell fragment, pretty cohesive and with a little bit three-dimensional feature. The nucleus pattern is a little bit unusual because a lot of them seems to have small nucleolus. So the patient actually had the advanced stage of prostatic cancer. So these cell cluster, first of all, in the voided urine, usually we don't have cell cluster. And sometimes if it's a tumor, the cell cluster can be entirely detached. Sometimes if the patient had a stone, it can be detached, so you will have larger fragment. But the fragment can be either benign or malignant, so you have to pay attention. So for this one, it is very three-dimensional, and it has some bubble in the cytoplasm, so it seems to be a little bit like glandular feature. So if you put it into a body fluid, pleural cavity, you would definitely think, okay, this is could be a adenocarcinoma fragment. So this is why we suspect that these probably be the detachment from the prostate cancer, prostate adenocarcinoma. We do a cytospin for prostate marker NKX3.1. However, in the cytospin preparation, there's no more cell cluster anymore. So we call these suspicious. But the based on the cytomorphology, it looks suspicious, very suspicious for prostate cancer involvement. So the next specimen is a body fluid specimen. It is from ascites. The clinician submitted two separate specimens. The first specimen is only 3 millimeter. So it is a very scant specimen. In this specimen, we do see one unusual cluster with three-dimensional feature and some large vacuoles in the cytoplasm. So this one looks quite suspicious for adenocarcinoma. It is a male patient. If we encounter a female patient, we would think about gynecologic, like a primary peritoneal or ovarian cancer with abdominal cavity involvement. But because it's a male patient, we might probably think about, could it be from the GI tract or the other sources? So I checked the patient's abdominal CT. So in the CT report, it shows that it is highly suspicious for peritoneal carcinomatosis, but they didn't identify any focal lesion in the pancreas or in other like solid organ. However, if it's from the intestine, which is a tubal organ, the resolution of CT sometimes is not very good. The patient still need to do the endoscopic examination. So the second specimen from the same patient, it has 1,350 millimeters. So first only 3, the other is 1,000 and more. So sometimes in the large amount of specimen, the tissue processing will be difficult. And so in this specimen, we only see very scattered, like a three-dimensional cluster. The nucleus is not strikingly atypical, but the overall architecture seems to be very strange. So in this one, they do submit the cell block preparation. I think the only lesion is over here. So sometimes, even though the clinician give us more than 1 liter specimen, because it's difficult to process these type of specimens, so sometimes we don't see anything. But I think this is pretty definite for adenocarcinoma. It is more obvious in these focus. This one, I'm not so sure. It's likely an adeno because it's eccentric and with a prominent nucleolus. So probably these two are cancer, and the rest, I didn't see anything. So in this like very new patient, this would be the first diagnostic specimen. So we still need immunohistochemistry for confirmation. So we would do Claudin 4. I also do a MOC31 just to try to double confirm. And the origin is very difficult to determine. It's unusual to have an elder male with peritoneal carcinomatosis without any focal lesion. So the next specimen is from pleura effusion. The patient had a past history of primary lung squamous cell carcinoma. So he's a 71-year-old female. That is unusual. It is uncertain if she's a smoker or not. So in this pleura effusion specimen, we see a tight cluster with hyperchromasia. So remember what I said last week, for the squamous cell carcinoma metastasized to the pleura cavity, they have different like a cytomorphologic presentation. Sometimes they will form me a tight cluster, but with the flattened like a periphery. Sometimes they look like high-grade adenocarcinoma. And sometimes you will just see a lot of keratinized material. So I think for this case, it does looks like adenocarcinoma. If you ask me which one to choose based only on the cytomorphology, it looks exactly like high-grade adenocarcinoma with eccentric nucleus, vesicular chromatin, chrominant nucleoli. So it is unlikely to distinguish these from the usual adenocarcinoma that we see. So we call these non-small cell. However, because we do have a cell block, so we would do a P40 to try to demonstrate that. I find it is not uncommon to see SCC looks like adenocarcinoma in the like a body fluid specimen, and it is not very well like characterized in the literature. So this could also be a good research project if anyone is interested. So let's move to the fine needle aspirations. So this is a thyroid aspiration. On low power, it is hypercellular, but the colloid seems to be pretty scant. And you see flattened sheets. You also see some like papillary pattern. So this is highly suspicious for PTC just based on this low power feature. Here you see a multinucleated giant cell, which also gives like a high suspicions for PTC. So this is a multinucleated giant cell. So whenever we want to diagnose PTC, we need to check the nuclear feature. So PTC is a nuclear diagnosis. So in this fragment, we do see 1, 2 pseudo inclusion, probably a little bit more in other area. So it is, so there's another one over here. So in this fragment, we see 3 pseudo inclusion already. So this is a pretty classic papillary thyroid carcinoma. So in this fragment, you also see 1, 2, 3 pseudo inclusion, 4, 5, 6, a little bit more. So this is very good for positive TBS6 PTC diagnosis. The other one is more tricky. So this is a different thyroid aspiration. In this specimen, it is paucicellular. We only have scattered fragments of cells, but also that we notice in the background, the colloid is also very scant. So we go to higher power. The nuclear feature of this case is also highly suspicious for PTC, but we didn't identify a single pseudo inclusion. So usually in this scenario, the lesion can be really tiny. So I checked the sonography finding. It is a less than 0.5 centimeter lesion, and it is hypoechoic, which is a classic sonography finding of a PTC, but it is just very, very tiny. So in this scenario, I turn to call this suspicious instead of frankly positive because it is a very tiny lesion. Sometimes when the patient receive thyroidectomy and they can like the lesion can be cutting through or some other problem causing we didn't identify it. But here you also see this is pretty much like a very good papillary architecture. You have a fibrovascular core, you have cell lining around it. So this seems to be a papillary, a papilla, a detached papilla. So we do have a few cells with highly suspicious nuclear feature for PTC, but we didn't identify the pseudo inclusion, and it is very tiny, so we call it suspicious for PTC. So the next specimen is from the neck lymph node. So in the short pass preparation, it is very like a hypocellular. We didn't see any like cells. We only see a few seems to be histiocytic cells instead of like lymphocytes. So this seems to be histiocyte. This is PMN. These could be a lymphocyte, but just very scant. However, in the direct smear, we do see two cell cluster. They got a little bit histiocytoid feature. So it is uncommon that you see the histiocytoid cells in the lymph node. This seems to be a multinucleated giant cell. So overall, this a little bit spindle epithelioid cell seems to be like granuloma. So this one looks a little bit like granuloma, but these are definitely histiocytoid looking. So the other fragment seems to be a little bit more epithelian, but it's still very difficult to tell. And then we checked the history of the patient. He had the past history of thyroid PTC with total thyroidectomy and lymph node metastases. So clinicians suspect that these lymph nodes have metastatic recurrent disease. So we only have a few like cluster of atypical histiocytoid cells without definite cystic background that we usually see. So in this specimen, we call this atypical, scan atypical histiocytoid cell. It is still a chance that they are PTC in the lymph node, but they just didn't sample it. The next specimen is a pap smear. The patient is a 32-year-old female, so relatively young. She received HPV testing and concurrent pap smear. So we already released the HPV report. This is the pap smear like sampling at the same time. The HPV result turned back to be positive for high-risk HPV, but it is a non-16, non-18 other high-risk type. So whenever if we already know the history of high-risk HPV, we will usually be more like cautious when we do the screening. So in this area, we start to see very hyperchromatic cell. So when you see a typical cell again, first of all, you need to check if it is a squamous origin or it is a glandular origin. So here, this is a benign endocervical glandular cell, right? But this one is more spindle, and this hyperchromatic pattern, coarse chromatin pattern, this is compatible with a squamous cell. So we have benign endocervical gland, and a typical squamous population. So this is sampling from the T-zone because it is right adjacent to each other. So this looks like a squamous lesion. This one, there's no cytoplasm, so we cannot make judgment on this one. But this one also looks suspicious, no cytoplasm. And yeah, here again, this is hyperchromatic. And we have spindle cells like lying down at the edges of these cell cluster. So this looks like a high CO. So we always have to be really cautious. So here again, we do see these typical cell. If this is the only cell that we have, it is a bit uncertain. I think it is, we won't be really confident to just call it high CO right away. For these focus, probably we would call dysplasia cannot rule out high CO. If we have a little bit more, we can call it CIN2. But these guys, I think is definitely high CO. Okay, so here again. So it seems to be there are a little bit of mucus cell somewhere, but this one is also hyperchromatic. So it seems to be a little bit like metaplastic area. And there is a diagnosis called SMILE, if you heard of that, which is like a high CO lesion, but still with a mucinous differentiation. I'm not so sure if this is the case, but it could be. And here, this is also a squamous cell with high NC ratio, hyperchromasia, coarse chromatin. So I think this one is pretty definite for high CO, right? So it is not only ASCH, it is high CO. Here, uncertainly why there are nuclears. But yeah, but sometimes the morphology can be quite ambiguous. So this one I would say is a bit ambiguous because this one looks like a repair, right? It has a definite repair feature. However, some of the cells seems to be really, really hyperchromatic. So if this is the only one that we see, we could call this ASCH, right? ASCH, because the differential is between high CO versus repair change. So anyway, just when you see, this is the advantage for direct smear, conventional pap smear. When you see something atypical, you just need to go through the entire smear direction to identify more cell, then you can be more confidently to call it positive. So this one I think is also positive. This one is between dysplasia, I cannot exclude high CO versus CIN2. If it's more hyperchromatic, I would probably call it CIN2. But this is just you have to see the entire specimen to do a good diagnosis. So overall, I think there are some ambiguous morphology from area to area, but there are definitely some positive area. So here again, I could call this dysplasia, cannot exclude high CO, but it still also have a little bit of repair type of changes, right? So this is positive. So since we are doing the HPV testing now, I think our screener need to pay attention of the HPV results. Yeah, so this one is positive for high CO, and not only the type 16, 18 cases can have high CO. And in our experience so far, other high-risk HPV also are quite common to have high C. So this is positive for high C. Okay, so that's it. And 我们开始招那个新的医检师，